Good afternoon, everyone. My name is Nathan Johnson. I'm with the Healthcare Authority, and we're going to get the webinar underway today. Just with a quick few administrative details here at the outset to make this a pleasurable and productive experience for everyone. First, with regard to questions that may come up, we will be pausing at the very end and leaving plenty of time. We've made time on the agenda today for your questions. Please submit those through the online questions pane throughout the webinar. And again, we'll be theming those and addressing as many as we can possibly get to at the end of the presentation today. If you cannot hear us now, you probably can't hear these directions, but you can read them. And there's a few elements there that folks can work on to get video flowing. Also, there's a way to go to the website, gotowebinar.com for support, or you can join us directly via telephone, and the instructions will be in your webinar pane. Now, briefly to introduce who's going to be talking to you today. Again, I'm Nathan Johnson. I have the pleasure of serving as the Chief Policy Officer here at the Healthcare Authority. I'm joined by several colleagues who I'll introduce briefly, who are subject matter experts and will be taking you through a lot of the substance today of the presentation. First, MaryAnne Lindeblad, our Medicaid Director for the state of Washington. Marc Provence, who leads the work of Medicaid Transformation at the Healthcare Authority. Bea Rector, who is the Director of the Division of Home and Community Services at DSHS. Chris Imhoff, who is the Division of Behavioral Health and Recovery Director at DSHS. And finally, Melodie Pazolt, who is the Program Administrator at the Behavioral Health Administration for DSHS. And moving on. For our topics today, several things we are going to try to cover. First, we're going to have an update on some CMS conversations, where we are at today in a very active and dynamic negotiating process. We'll discuss with you on a broad timeline basis key milestones that we must hit for waiver approval. We'll talk about progress on the various waiver initiatives. All three of them will be covered in today's discussion. We'll give you a sense of some next steps that are ahead of us, and again, I'll be taking your questions throughout this presentation and addressing them from the panel at its conclusion. I will also mention here that we are diving right into this discussion at a level of depth that may be a little hard to follow if you haven't been able to participate in previous webinars or haven't been able to read some of the supporting materials. So with apologies for that, I would encourage folks who do struggle to follow with some of this information that there are plenty of places where they can find some further information, either as part of following today's webinar or at its conclusion. Sample resources available to you at the link include stakeholder and tribal input received throughout this process, several fact sheets highlighting elements of the initiatives that are proposed, the waiver application itself, as well as previous webinar presentations and updates, real-time updates really on the work group activities. So briefly going to the CMS update and some key messages that I will share with you out of those discussions. First, our application, as folks know, was submitted in August, was reviewed in a period after that time for its completeness, rendered complete, and then was subjected to an additional 30-day federal comment period. And thanks to all of you on this webinar who have participated actively in the state and federal process for comments. Since that time, we've had varying degrees of discussion, both over the phone, in webinar or video conference opportunities, much like this one, as well as most recently in person. Our report to you is significant progress is being made as part of the negotiation, and while there are still some steps to go, we are confident in the direction this discussion is headed. But a few key takeaways thus far that I think will inform the rest of this discussion today. First of all, and this will likely not surprise many of you who've been following this work closely, CMS is very focused on the value proposition, in particular, the value behind payments associated with the Medicaid program and how we can improve healthcare costs and quality through payment reform. CMS has it as a really nationwide mission to drive value-based payment in Medicare. They have set explicit targets for this in their Medicare program, and they especially want to use waivers like this to work closely with states to make similar progress with their Medicaid programs. We'll be talking a little more about that in coming weeks, but that is very much, I would say, a focus of our discussions today. The second piece is actually something we've been talking about even from the earliest conceptual discussions of this waiver that started in June. But it has been re-impressed over and over again, so we feel the need to mention it today. Sustainability of transformation efforts is required. It is a non-negotiable item for CMS. They do not want to see a 5-year waiver with terms and conditions such that we come back to them 5 years from now asking for another investment or additional expenditure authority. So this is a very true statement here. Investments need to be the catalyst for reform, but not ongoing operating budget expansions. This is a commitment that we have made to the overarching waiver and explicitly for each of the 3 initiatives. Related to that point on sustainability, but from a broader perspective, CMS has a concern across all of these waivers, including in this waiver discussion, that investments do not displace regular Medicaid payment arrangements or other federal financing. This waiver discussion is not about supplanting existing Medicaid expenditures. And if it were, we would not have a friendly audience with CMS. But they want to ensure that the scope of investment and what we're buying through federal dollars are not supplanting or displacing Medicaid expenditures now, over the next 5 years, or after the 5-year period. And finally, CMS has again and again expressed their support for the overarching concept involved in this entire waiver of bringing key health and social service agencies together to address those determinants of health outside of the clinical care delivery system. This is part and parcel of all 3 initiatives, in particular transformation led through accountable communities of health, our approach to long-term services array, and especially supportive housing and supported employment. So a little more specifics on the status of current discussions. This, again, may not surprise some of you, but a primary focus on the financing. Folks will be aware that in the waiver application, the state has made a request for $3 billion of federal investment over 5 years in support of the 3 initiatives. We made this request acknowledging with you all in the beginning that this was a starting point for the discussion. And to appropriately manage expectations, we are quite aware, quite familiar that we will not be getting the full amount of this request. But it has, I think, focused CMS on the scope and breadth of our effort, and they understand very much the significance of it in this state, which is good. Related to financing and to our investment ask, federal budget neutrality, which is the box in which every 1115 waiver must fit. That is to say, from a 5-year standpoint, the federal government has to see how waiver expenditures will be offset by enough savings over the 5-year period such that the federal budget is not bearing any additional expense for our Medicaid program. Again, so that is a theme that factors into all 3 of the initiatives under this waiver. The other factor that's of primary focus is the approach to a provable state match. As we have discussed before, we are not proposing nor providing through this waiver additional state expenditures to drive match. We intend to leverage expenditures that are already occurring and have some nexus to the Medicaid program but are not being matched today. So CMS will ultimately have to approve those non-federal sources of funding, and we are in active discussions around what that can look like. There is momentum in discussions across all initiatives, and we believe we have absolutely by now reached the point where the program and policy elements of this waiver are both well understood and generally supported, with more specifics to be worked out. We'd also acknowledge, and CMS has acknowledged directly to us, that there is a compressed timeline, and that timeline poses challenges. We have been upfront in prior discussions that we are working towards April 2016 approval of terms and conditions, and that work continues. A new element in this discussion is, and a change from previous presentation materials you may be accustomed to, is CMS will require for our state adherence to a traditional 5-year 1115 waiver window. In our application and in prior communications, we had talked a lot about year 0. And so the concept of ramp up and an implementation period still applies, but that ramp up period will be taking place in the 5-year window, not as an additional time period prior to the 5-year window. So I think that's important to emphasize. I would also think to emphasize here how, with regard to Initiative 3, one of the key questions from CMS to us has been how this is not just an extension of additional benefits, how this is not just expanding service array. And I think the point we have been able to make with them, and I think a recognition that they now have, is that our approach to Initiative 3 in concert with the other two initiatives is very innovative in that it is approaching targeted services for populations where cost offsets may occur, paired with the necessary care transformation investments to ensure it's not just the wraparound services in support of housing and employment that we're purchasing, but actually the linkages to the clinical care delivery system that are so essential to achieve the whole person care outcomes that we're after. This is something I think CMS appreciates, and I think this is a unique approach that this state is taking compared to other states on this front. So it's my privilege now to turn over the mic to my colleague MaryAnne, who is going to walk us through the next several slides.
Thank you, Nathan. And for those of you that have been watching this initiative and have seen this timeline slide before, you can see that star, and it has certainly moved in the direction that, quickly and moving right along into the negotiation and outreach phase. So this phase, so that third phase, will end at the completion of the negotiations with CMS as they draft the special terms and conditions for it, of which then we'll have about 30 days to review those, agree with them, and then that also includes an opportunity for stakeholder input and comment on those special terms and conditions. So that really is becoming the next big hurdle once we resolve the issues that Nathan mentioned. Then CMS will have some time to respond to our responses, again, a bit of a negotiation. But once we have those special terms and conditions signed, funding can start to flow. The important piece of that is we can start getting some money to start building out some of the infrastructure. This timeline takes us to the summer of 2016 to get the waiver approval, finish the design of the critical elements that CMS will be requiring and be engaged with us in that waiver approval. And I know when you look at this timeline, it seems quite compressed. I think it's very important, though, that we work to meet this timeline and get through to get this phase 4 done by the end of summer. We get much farther than that, then it starts to become getting into the next presidential election, and certainly the ability of CMS to further negotiate these sorts of waivers will become limited. So we have a lot of work to do, and certainly more details will be forthcoming as we get that first round of special terms and conditions from CMS. So this is just a little bit of a reminder slide, and folks have seen this before if you've, again, been tracking this initiative. But just a reminder quickly on our transformation goals, and certainly looking at how we can reduce the use of intense services and settings, hospitalizations, some of the long-term care services, more traditional jails, psych hospitals, a big piece about improving population health, looking at prevention, and certainly these disease states that we mentioned are options, opportunities, certainly broader than that. How do we accelerate the transition to value-based payment, looking at payment methodologies, getting away from fee-for-service, and payment methodologies that really focus on quality and outcomes. And when we talk about the kind of savings that we can achieve, it's the ability to ensure that our per capita cost growth is below national trends. And when you think about and you look at these two, they fit very nicely and actually mirror what Nathan mentioned earlier as some of the goals that the federal government has for this project for us also. So again, just a reminder as we move into the next set of conversations, the 3 initiatives. So again, that first initiative about transforming through accountable communities of health. And this is really one of the unique aspects. Well, actually, all 3 of these are unique in the sense of what we're moving forward with. But as we talk about the ACHs, this is something certainly that in our conversations with CMS, they're very interested in this sort of community level of engagement and what we were doing and at that accountability and sustainability at the community level and the proactive nature of the community and how we move these initiatives forward. So Initiative 1, again, using our ACHs, is, again, one of the things that when we talk to CMS about what we are modeling or what we're testing, this certainly is an important aspect of it. Initiative 2 that we've talked about is looking at services that will allow some of our seniors to stay at home and delay the need for more intensive care. Again, unique and proactive related to the work that we're doing, and how do we, as a state, address concerns about the baby boom. And then lastly, Initiative 3 is that targeted support of supportive housing, supported employment, and offering those to Medicaid beneficiaries that really will benefit most from these services, and how that fits in with the larger strategy at the community level. So again, just a reminder of what those are. And what I'd like to do now is transition to Marc Provence, and he is going to walk us through Initiative 1.
Thanks, MaryAnne. So just not to put too fine a point on it, but to remind you in terms of our accountable communities of health, this map shows you the regions in which the ACHs operate. As many of you may know, all 9 ACHs have been designated at this point, which is a significant milestone in our state innovation model grant. So as you'll see as we talk, the ACHs have in fact been engaged to a significant degree in the generation, fostering, encouragement of the project ideas that we've received. So thanks go out to the ACHs and their members and leaders. We would be remiss if we didn't start by thanking you all for your enthusiastic, energetic, creative approach to our solicitation of project ideas. And if you haven't heard it yet, we received 180 transformation project ideas. We were quite pleased with the response that we got. These ideas demonstrate really a high level of community managed care system, provider, social service, and advocate engagement. We had quite an array of respondents represented, both in those who actually submitted the project ideas, but also the partners that they named as they submitted those ideas to us. And those included associations, professional societies, local health departments, first responders, nonprofits, advocates, healthcare providers, and of course the ACHs. So it's quite an impressive collaborative effort, and we really appreciate that. The ideas also demonstrated a clear commitment to health delivery systems transformation, which, to echo what Nathan and MaryAnne said, is quite significant in terms of advancing our negotiations with CMS. These really do need to be transformative projects, and we got quite a ways along that path, I think, based on the ideas that we received. And we did see many instances of community partners working together to meet shared goals. I would like to remind those of you who may not know this that the project ideas have been posted on our website, so you can actually go there. And if you have the interest and the patience, you're welcome to read all 180 of them, but you'll find that there are some quite remarkable ideas represented. The reason that we requested and why we needed transformation project ideas is that, again, we need to demonstrate that what we're doing addresses community health needs, and that's why we invited these ideas to come up through the communities and through their representatives, and to reflect priorities and perspectives of community members and providers of care. As you can see here, the input and suggestions that you've contributed will help to clarify gaps in our initial framework, and we'll talk about that framework in a moment, as well as any needed refinement. So rather than us sitting and trying to decide on our own and from our perspective what communities might need and what a project collection of project ideas might represent, with your help, we've been able not only to identify major themes, but also begin to identify if there are any gaps in the project ideas that have come forward. The other thing that this enables us to do is really share ideas across regions and communities. Again, I'd encourage you to look at the project ideas. Many of you have already collaborated in the submission of those. But what we're hoping is that in large part, the ACHs and their communities can learn from one another. That's really a big driver behind the approach that we're taking rather than being prescriptive. This also helps us to build criteria for selecting projects that have the greatest delivery system reform potential. And we'll talk in a moment about what those criteria look like. And then finally, and very importantly, your help and your ideas will help us make a convincing case to CMS for the promise of Medicaid transformation in our state. So in our preliminary review of project ideas, I'm sorry, do we have preliminary, I may have we skipped over a slide? Oh, okay, sorry. I'm following the wrong order. See, this is designed to keep me on my toes. So the process for developing a project toolkit framework is outlined here. So we did solicit your project ideas and received them in December. And as you can see with the yellow box, we're in the process of reviewing the project ideas submitted. This timeline, once again, proceeds on the assumption that we will have waiver approvals in April. So that's, to echo what MaryAnne said, it's a compressed timeline. It's achievable, but we are very actively reviewing project ideas at this point. We're looking at them relative to criteria, which I'll get to in a second, and creating a framework for our continued discussion of these ideas with CMS as we go forward. Now to preliminary review of project ideas, and we mentioned criteria, and I hope these are not a surprise to any of you, because if you have followed our work to date, you will see that these derive from the project guidelines, project submission guidelines that we issued when we requested our projects in December. They derive from the webinar that we held with you in December as well. They're part and parcel of our waiver application. So there should be, if you reflect back on that history, consistency in what you see here. And these are pretty straightforward. Is the idea clear and feasible? Is there evidence that the project promotes community collaboration? We've talked about that a bit already. Does it support Medicaid delivery system transformation goals? And this harkens back to an earlier slide where MaryAnne reminded you of what our transformation goals are, having to do with reducing avoidable use of institutional services and settings, improving population health, accelerating transition to value-based purchasing, and ensuring that Medicaid cost growth is below national trends. Again, CMS is going to be looking at what we finally submit relative to those goals. Is the idea focused on the Medicaid population? It's very important to remember that, in fact, this is a Medicaid transformation proposal and activity. Is the idea based on evidence or promising research? We did ask for that in the project idea submissions, and thanks to those of you who were able to cite either evidence or promising practices. Does it address a significant need and improve health outcomes or reduce avoidable expenditures? Is there a potential for return on investment? Again, a very significant interest of CMS. And does the project idea have the potential to be sustainable at the end of the waiver demonstration? So on the next slide, this I referenced earlier our framework, and this is the way in which we're beginning to from the project idea stage to really what a collection of projects would look like as we move forward in our discussions with CMS. And it really starts from our project domains. And as you'll see from the comment at the top, CMS does want to see our project toolkit framework, and so we have a refinement process that we need to go through. The domains, again, are those that we've had all along and were in our project idea request. And those are health systems capacity building, care delivery redesign, and population health. From those domains, and kind of working down from the domains and working up from the project ideas, are strategies that are emerging as we begin to look at the ideas that have been submitted. You can think of a strategy as really a plan or a method of acting that gets us to the kinds of transformation and reforms that we've talked about in our goals. And then from those ideas, thinking about the strategies that we want to pursue will ultimately come our collection of projects. As you can see from the arrow, your ideas really are shaping the strategies and providing rationale for CMS approval. And just to give you a couple of examples which might make it easier to understand, if you think about the domain of capacity building, for example, A strategy under that domain may be to improve the use of our workforce. And a project within that strategy might be something like telemedicine to improve specialty access in underserved areas. Again, if you think about care delivery redesign, a strategy might be care integration, and a project might be co-location of behavioral and primary care providers. And finally, if you think about population health as a domain, a strategy would be chronic disease prevention, and a project might be diabetes management in high-risk populations. So you can begin to see how these interrelate. And what we received were many ideas, some of which had very familiar themes. And in the process of reviewing the ideas, we're not only looking at them independently, but we're looking at them collectively to see where those relationships can be developed and fostered so that we end up, as we've said all along, with a project menu, a project collection that is not so overwhelming that it distracts us in CMS, but can really focus on the kinds of strategies that get us to the transformation that we're after. So impressions, no, I'm not going to do impressions. Impressions during our initial review. We did see clear evidence of innovative thinking and community collaboration, and we thank you for that. And again, we saw some very clear themes emerging, and we will be saying more about that to you in subsequent communications as we begin to group these ideas together along the methodology that I just described. And some key questions to consider as we've been reviewing these ideas. Can a project idea ramp up implementation planning quickly? Once again, we now know we have a 5-year demonstration period. That does not leave us a lot of ramp-up time at the beginning. We really want to get these projects underway so that we can begin to evaluate their effectiveness. Can the project be scaled to have substantial impact on the delivery system and its transformation? Again, delivery system transformation is really the key underlying theme, and especially from the CMS perspective. And does it drive towards sustainable delivery system reform over the course of the waiver and, frankly, beyond the course of the waiver? What we also discovered is that we probably need to provide more education of how the projects are supported through performance incentive payments. And as a reminder, these are not grants, and we need to be able to tie the payments that are made under the waiver to process and outcomes milestones. And speaking of milestones, so these are examples really of the kinds of incentive payment milestones that we have and that we believe HCMS has in mind. And you'll see from the reference at the bottom, and I would encourage you to go there if you haven't reviewed this MACPAC report. These are from the Medicaid and CHIP Payment and Access Commission report in June of 2015. But we think it's a very useful and a very illustrative model. So when we talk about milestones for the conduct and the review of a project, you can see those move from planning through project implementation, reporting, and results. And you can see in the boxes the examples of the kinds of activities that are included under each of those headings. And as you see at the bottom, initially payments will focus more on process-oriented changes, and again, we've said that in prior communications. But the focus will have to shift to more outcomes-based measures, and again, because of our concentrated timetable, it'll be very important to move quickly from those process milestones to the outcome milestones. So next steps on transformation projects. First and foremost, to continue the review of our 180 project ideas, really is a step toward developing that project toolkit framework that we described on the previous slide. We do continue to welcome your public comments on these slides. Those will all be posted on our website, and that's open until Sunday, February 21st. The website is there for you to send your comments to. We will share our key findings, and next steps and timing really depends on our CMS negotiations. I will take a moment here to remind you that if and as you have questions during the course of this webinar, please do submit them using the question pane. And with that, I will transition to Bea for a discussion about Initiative 2.
Good afternoon. I want to echo what others have already said, which is our deep appreciation for the level of engagement that we have, and in particular to our long-term services and support stakeholders. You guys have been very present with us through some stakeholder engagement meetings and have helped kind of shape where we are today. And so really the intent of this presentation from my perspective is also just to give you an update, because we have had some changes in our proposal between the application and our current thinking that has been shaped by some of the feedback that we've received along the way from all of you. So our work, just as a reminder, in the Long-Term Services and Supports Initiative 2 has been really focused on two key things. The first is a desire that we have to provide community-based long-term care services under our existing federal authorities, which is a fairly low level of functional eligibility for services, which is currently linked with the same functional eligibility for nursing home, which is quite low. And we have wanted to be able to, with this 1115 waiver, delink those things, maintain this lower functional eligibility for care in people's homes or in licensed residential settings, which are adult family homes or assisted living facilities, while increasing slightly the functional eligibility for nursing home care. The reason behind this is really, as we look at this age wave, we look at the doubling of the 60-plus population in Washington over the next 20 years. We know there's a very strong correlation between age and functional disability and the need for potentially higher levels of care. We want to make sure that as that happens, we've got nursing home beds available for our highest need clients in the continuum of our long-term care service delivery system. The second thing that we have been focused on is the creation of additional targeted services and an additional eligibility group really designed to delay and divert individuals from needing the more intensive services that traditionally have been provided through our Medicaid long-term services and support system. So in terms of the delinking, this was the changing eligibility for nursing home care. We have had a couple of follow-up conversations since submitting our application to CMS with the disabled and elderly group, which is the group of subject matter experts at CMS that work in the various federal authorities that we can use to draw down Medicaid dollars for long-term services and support. Because our state is planning to run our 1115 waiver parallel with other home and community-based authorities, which in Washington include a 1915K and a 1915C. We're moving microphones because I think there's some difficulty with hearing. What I was saying is our approach has always been not to fold our existing HCBS authorities underneath the 1115, but to run that 1115 parallel to our existing authorities, which are 1915K and 1915C. CMS has let us know because of that parallel running of authorities, we really can't do what we originally proposed doing to delink and use the 1115 to do that. Having said that, they did say it is possible under our existing home and community-based authorities to do this delinking. And one of the things that we've learned in our conversations with CMS, that if you can do things in your existing authorities, then you don't need an 1115 authority, and it's not something that's going to get approved that way. So we have let CMS know that we are not going to pursue the delinking as part of our 1115 application, but that we would like to pursue this policy goal at a future time. And so we're going to focus our energies on the MAC and TSOA benefits in the 1115, and we'll come back to this delinking probably sometime after the summer or perhaps fall and pick up that part of our conversation with stakeholders. So what I want to do is talk about our other two components of Initiative 2, the Medicaid Alternative Care, which is a new choice designed to support unpaid family caregivers in continuing to provide quality care. If an individual made the choice to enter the MAC benefit, they would not receive services under 1915K or 1915C, or even our optional state plan personal care benefit. So this would be another choice for Medicaid eligible individuals. If they wanted that family caregiver support, they would enroll in the 1115. If their needs changed, they could disenroll from the 1115 and access our existing Medicaid long-term services and supports. The second program is called Tailored Supports for Older Adults, and this is really a new eligibility group, a group of people who have too much money to qualify financially for Medicaid, but not a lot of money to purchase out-of-pocket long-term care for very long. So this is really an at-risk population, and what we're trying to do is to provide a benefit, a small benefit to them that would delay or divert them from having to come on more intensive Medicaid services. So a couple of changes that have happened. The writing in black on your screen are the same. Those are things that we proposed in the application that have not changed. The age target is 55 plus. We will not have a state recovery for individuals that come into the Medicaid alternative care benefit. There will not be a cost sharing requirement. The resources have changed, however. We originally said there would be no specific asset level test, that people had to be Medicaid eligible, and in our conversations with CMS learned that the spousal impoverishment rules that apply in many of the authorities for HCBS will apply in the 1115 as well. So we will have that spousal impoverishment protection, which is a good thing. In terms of income, folks have to be eligible for Medicaid. And originally, we were targeting less than 150% of the federal poverty level. Instead, we're looking at existing Medicaid eligibility groups, categorically needy, and alternative benefit plans, which can have higher limits than the 150%. The reason for that change is if this is going to be a choice for individuals who are otherwise eligible for long-term services and supports, you want to make sure that if that no longer meets their need and they want to make a different choice, that they can easily transition between programs. And so if we have the same eligibility financially across the programs, people can slip between these programs quite easily and not have to go through a new application process for Medicaid. The tailored services for older adults, the at-risk of Medicaid population, again, same age, 55 plus. In terms of income, we originally were saying 300% of the federal benefit rate. That's about $2,100, $2,200 based in 2016 standards. There isn't a change, but again, we will have to use the spousal impoverishment rules for this population as well. Originally, we did propose some cost sharing. You know, we thought that if we provided a service like respite, and depending on income, there should be a sliding fee scale. Since then, we've changed our mind on that, primarily because it's a very small benefit amount that people are going to be eligible for, and it's very administratively burdensome to operate a cost-sharing program. And so to reduce that, that administrative complexity, we're not going to have any kind of participation. And there's also very limited ways that you can have participation in an 1115 waiver, which we learned after our application went in. A state recovery will not apply. That's not a change. And originally, we thought of having no asset test, but given the need to ensure sustainability, given the need to prove that return on investment, we've decided we really should have an asset limit, and we want to target that to folks who are likely to spend down to Medicaid in a short period of time. So we'll have an asset limit of $53,100 for a single person, and then spousal impoverishment for a couple, which you see those amounts up there. And again, I talked about why an asset limit. We want to make sure that these are folks who are likely to spend down to Medicaid, certainly within the time period of the waiver, and in fact, a shorter time period, about 6 months in a nursing home at a private pay rate would have that person spend down to Medicaid. And you can probably double or even triple that, 12 months to 18 months paying private pay for home and community-based care for that same period of time. Just a reminder, folks coming on to this at-risk group are not eligible to receive medical benefits through Medicaid. They would only be receiving the services that we would provide in the long-term services and supports. And I am not going to go over this chart, but we wanted you to have it in your packet. This is what we have shared with our stakeholders that kind of shows the different eligibility groups for Medicaid long-term services and supports and how we see this adding to our continuum of care. And what you see in the colored areas are the ability to kind of move between these as your needs change. So that's just a reference document for your use later. In terms of our next steps, we have put on the web some additional detail about the benefits that will be offered both in the Medicaid Alternative Care Program and the Tailored Services for Older Adults Program. That is up for public comment through February 28th. We certainly welcome you to go there and provide us with comment about the benefits. Our discussions with CMS on our initiative are ongoing, as it is with the overall waiver. And we will continue to post materials as they become available on this particular initiative at the link that you have on your screen. So I want to take this time just to remind folks that if you have questions, to go ahead and type them into the pane on the screen, because we're going to come to those at the end. And I'm going to transition over to Chris Imhoff, who's going to provide an introduction for Initiative 3.
Thank you. The third initiative in this waiver we always refer to as foundational community supports. And that's because in any life, yours, mine, or the people on this waiver, employment and housing is so critical and fundamental. So it's a key strategy of our whole health approach. We've been developing both of these services through some existing stakeholder work that we're doing through the Housing 3000 Policy Academy and the Homestead Policy Academy for supported employment. There's still big decisions to be made, and we appreciate the stakeholders who are helping us make that. I'm sure some of you are on the phone. I know Melodie Pazolt, who we work together, has worked with many of you to make some hard decisions here. We're working through what makes sense in terms of rolling this benefit out across the state. Obviously, we want to go as fast as we can, but we want to do a really good job. So it's balancing those two things out. You'll see the phrase on the slide, encounter definitions, and it's surprisingly challenging to think, what is a service? Because many, many things can help a person maintain their housing. So what are we actually entering in our data system and saying, yep, that was a supported housing service. And that's what encounter definitions refers to. We have licensing and certification things to define because when you're paying for a service, you always need to have a structure that protects both from an auditing point of view and a safety and effectiveness point of view, and licensing and certification help us carry that out. And then when you're in a world of something as basic as a job and a roof over your head, what makes it medically necessary? Because that's what Medicaid pays for. So we really are looking at health in a different way than a Band-Aid. And that's why this is transformational. But it does make challenging questions, like how do we define this when we're still sort of stuck with paying through a Medicaid program that thinks medical. So lots of stakeholders, lots of providers are helping us think these things through. We really appreciate it. I'm going to turn this over to Melodie Pazolt, who can talk in more detail about our development process here. Thank you. Go ahead, Melodie.
Thanks, Chris. I think it's very fitting that we actually, starting out with the supported employment right after Bea's presentation around trying to interrupt people having to go into poverty before they get access to the services they need. And with the supported employment and supportive housing, we're actually trying to bring people out of poverty, and that really recognizing that long-term unemployment is very bad for your health, and that there's really significant higher rates of unemployment cause more illness and more premature death. And so there's a lot of data that says that long-term unemployment, there's many epidemiological studies that say that long-term unemployment is very bad for your health, not only your physical health, but your mental health. And people are more likely to use substances with long-term unemployment. And so how do we actually really try and think about supported employment as an intervention that affects people's health? And so we certainly, as MaryAnne also indicated on slide 9, that we want to focus on quality and outcomes. There are some pieces of legislation that were passed in 2013, Senate Bill 5732 and House Bill 1519, that really direct our systems, the healthcare system, the behavioral health system, and the long-term care system, to be focusing on meaningful client outcomes, as well as using evidence-based practices to do it, and research-based practices and promising practices. And certainly, supported employment definitely has a basis in research. The Washington State Institute for Public Policy has identified the supported employment or individual placement and support model as a research-based practice. Dartmouth, through the Psychiatric Research Center, and SAMHSA, the Substance Abuse Mental Health Services Administration, has actually identified it as an evidence-based practice. But this approach is very focused on a fidelity. There's been 23 randomized controlled trials using this model to demonstrate that this intervention has better outcomes in getting people employed. And the principles of supported employment, or the IPS model, are that the services are open to anyone who wants them, that individuals, regardless of their symptoms, regardless of actively using substances, if they want to work, that we help them and support them with employment. It's sort of the employment first model, similar to supportive housing. Supported employment and supportive housing are so parallel in the principles. The focus is on competitive employment, that we don't put people into artificial environments. We focus quickly on rapid job search, and we develop relationships with an employer. It's really about that matching process, developing a match between an employer and an employee, and supporting both of the employer and the individual through the process. And of course, the individual's preferences guide our decisions. That if somebody says that they want to work with animals, we don't go find them a fast food job. That really we're paying attention to what that person's interests are. Individualized long-term supports, that employment is great, it's healthy, it's important, but it's not going to solve anybody's problems, and that really oftentimes the long-term support are really necessary in terms of helping that person be successful in a job. And I think this is probably one of the key elements of this model that makes it different, and that it is integrated with treatment. That this is an intervention that was working alongside the doctors, the nurses, the therapists, the case managers, and that they're all working and collaborating together to help that person be successful. And of course, understanding how working affects people's benefits. So these services are targeted and meant to enhance existing services and demonstrate cost savings. I've been a practitioner in doing supported employment in my previous years, and really have seen where individuals say, now that I have someplace to go, something to do, I have purpose, I don't have time to think sit at home and think about my voices or think about all of the things going on in my life, and that really supported employment can be an intervention that really can provide cost savings for the system. Where we are today, the Homestead Policy Academy, and just for a little background on the Homestead Policy Academy, this was a SAMHSA-sponsored initiative, and if folks are familiar with the Homestead decision, a Supreme Court decision in 1999, that really, the Homestead decision was really about how do we help people fully integrate into the community. And so the Homestead Policy Academy really took that charge on. How do we help individuals fully integrate into the community, and that includes through employment. And so how do we, the charge of the Homestead Policy Academy, as we've developed our strategic plan to increase the employment rate for people with behavioral health conditions, how do we identify this, who's most likely to benefit from this service, and really be able to identify those potential cost savings and look at the details on the implementation of this benefit. So there's really been a lot of work through the Homestead Policy Academy. We're looking at some of these different issues that Chris identified, such as the service encounter definition, licensing standards, looking at how do we make sure that the individuals that are most likely to benefit from this and who we're going to see the most likely to see cost savings for the system. So those have been some of the conversations that we've been having. We're also continuing to do a lot of education and training on this intervention, as well as we do have a number of pilot projects happening, some through a SAMHSA grant, and then one pilot site we're using supported employment to serve individuals that receiving TANF that have behavioral health conditions, and also some individuals that are homeless. And so we have these pilot projects. Research and data analysis are doing the evaluation for that project, and we hope to identify really how this intervention is going to have an impact on people's the outcomes, certainly in getting people employed, but also the impact on different systems and perhaps also decrease in utilization. One of the things that we identified in the Homestead Policy Academy is really who's most likely to benefit from the supported employment services. In our initial application, the eligibility was quite broad, and we knew that we needed to narrow that down. And so with our partners at the Research and Data Analysis and the Healthcare Authority and the Aging and Long-Term Services Administration, we've been really kind of trying to narrow who would most likely benefit from this population or from this benefit. And so we've identified several different populations. We're hoping that we're going to be able to roll this benefit out and serve as many as we can in these populations, but this is where we think that we're going to see the most cost savings with the implementation of this intervention. And so the populations are the age, blind, and disabled population, and those individuals eligible for the housing and essential needs. If we can interrupt that path towards continued poverty, and really some individuals may need SSI, SSDI, but it's still poverty. And if we can intervene and try and support people back fully integrate into the community through employment with this intervention, we think we could potentially interrupt that cycle of poverty. We also identified individuals that with severe and persistent mental illness, individuals with multiple episodes of substance use treatment, or individuals with co-occurring disorders. Another opportunity, I think, really in having an intervention towards that spiral into poverty is, could we use this service also for youth in transition with behavioral health issues that may have their first episode of psychosis, and really be looking at potentially a lifelong involvement in this system. Could we have this intervention and, again, truly help them integrate into the community with employment, supported employment? One of the things I do want to also point out is that we also could serve individuals both in the supportive housing benefit as well as the supported employment benefit. It could be a concurrent service if people are eligible for both of those services and meet the medical functional need for that. This benefit is also going to be available through the ALSA population, the Aging and Long-Term Services Administration, for their population, and would run this concurrently. If we were to phase in or prioritize those populations, ALSA concurrent benefit would be separate from that phasing in approach. So now to the supportive housing. The supportive housing, again, very similar in the nature of the intervention. I think that everybody would agree that housing is important, and again, kind of taking off of what Bea was saying earlier, how do we help people really think about that they don't have to go into these higher cost services? And, you know, housing is such an important part of people's recovery. We had a story from one of our pilot projects of an individual that needs to have a hip replacement surgery, and he's currently homeless, and they won't do the surgery because he's homeless, and they can't get into the housing because he has all these complicated issues. And so so it's really kind of this cart and horse. How do we really marry these services together? It is a whole health issue: housing, the support services, and the healthcare services. So housing transition services that provide direct support to individuals to obtain housing and maintain housing. I really want to point out that CMS actually created, it was very timely and wonderful that CMS issued a policy bulletin in June of 2015 that actually described their perspective of supportive housing services. And so we certainly are aligning the benefit with CMS's guidance. And that, you know, we really do want to point out that these services that we're not talking about paying for rent subsidies or the development of housing. But we're talking about this intervention really being a support to help somebody obtain housing and the services to help them maintain their housing. And all of the principles that I was talking about earlier with supported employment are very parallel to supportive housing. How do we give people choice? How do we empower them? How do we help them identify housing that meets their needs, and really developing that relationship with the landlords and making a match between a landlord and an individual, and supporting that, both of them, through that process. So where are we today with refining the critical policy elements? We have also, through the Chronic Homeless Policy Academy, we've been really looking at this intervention and what would this look like? How could we develop that marriage and those relationships between the housing system, the subsidies, the housing stock, with the service providers that would be eligible to provide this service either through the managed care organizations, behavioral health organizations, or through aging and long-term care services. So we've been developing some work groups to look at certification standards, the service encounter definition, establishing that medical functional necessity criteria, and really trying to do a lot of education and training on the evidence-based practice supportive housing services. Again, on the WISP standards, on the WISP inventory under 5732 and 1519, supportive housing services was also identified as a research-based practice. So we identified 5 populations that we thought in the 1115 application that would most likely benefit, and where we would see the highest opportunity for savings. And so those populations are individuals that meet the HUD definition of chronically homeless, which is 4 episodes of homelessness in a 3-year period, or 1 year of homelessness, and a disabling condition. Individuals with frequent or lengthy institutional contacts, individuals with frequent or lengthy adult residential care stays, or those with the highest risk of expensive care and negative outcomes through the PRISM risk score. And certainly there's a lot more information on the HCA website on the PRISM risk score, as well as this initiative. So with that, I'm think I'm going to point out that also with the ALSA benefit, this is also would be a concurrent benefit that also would implement that at the same time as we are looking at implementing this within the behavioral health and healthcare system. I'm going to turn it back over to Nathan to answer the question and answer portion.
Great. So we're going to give some folks time to get their questions in, even as we start to get to some of the first few that have trickled in this afternoon. Again, thank you everyone for being with us for the duration of the first half of the presentation, but now we're into the, I think, more meaningful part of the discussion with your questions and answers, or at least approaches to answers that we can provide. So I'm going to ask the team to catalog whatever we have so far and get the questions disseminated, and I think we have for members of our team. And then what we'll do is we'll read the question so folks have a sense of what we're responding to, and then if we have an answer, we'll offer one at this stage. I'm actually going to look to my right, Bea, if you'd like to start us off with Initiative 2 and a question that's come in for you, I believe.
Okay. I'm going to test and see if people can hear because we're kind of between mics here. So the question is, can you explain the spousal impoverishment limit more? And what spousal impoverishment means is typically under Medicaid rule, folks cannot qualify for Medicaid if they have more than $2,000 in assets. And then there's an income limit in addition to that. When somebody is part of a married couple, you don't really want to have the couple have to spend down to $2,000 total between the two. And you would impoverish not only the person who is receiving Medicaid, but also the spouse. So under spousal impoverishment rules, you can transfer assets up to $54,726 from the recipient, the person applying for Medicaid, to the spouse, and not have that count against the recipient in terms of eligibility for Medicaid. So what that does is give the spouse some assets, obviously, to live on. Doesn't impoverish them totally. And then the recipient can become eligible for Medicaid. So again, we learned after submitting our application that the spousal impoverishment rules do apply to 1115 waivers. And so originally we had not intended to have to go through that particular financial eligibility step in determining eligibility for TSOA or MAC. And both will have that apply for married couples.
Thanks, Bea. We have a few questions on a similar theme to one of the earlier elements that MaryAnne and I both addressed, which is with regard to year 0 and the treatment of a ramp-up period. I would like to go ahead and address those now. Questions came in with regard to the implications for ACHs as coordinating entities if there is no year 0. Will HCA staff be available to help deal with this? And what would happen to existing backbone organizations if they become coordinating entities under the waiver, which is slightly different. I'll get to that in a moment. So the first question with regard to implications for coordinating entities with year 0 is from our prior statements and discussions around timeline. The implication is a shorter project period, not a shorter ramp-up period. We recognize the need to ramp up both state, community, and delivery system capacity to implement projects, and this doesn't just apply to Initiative 1, it applies to ramp-up period needed as well for Initiative 2 and Initiative 3 service delivery. So that is our perspective going into it. Of course, our preference would be to be provided a year 0 opportunity that would not cut into the 5-year demonstration, and that's the preference we led with in our application. But given the clarity of thought that CMS responded with very recently, we thought we would share with you all where this is headed. But again, to be 100% clear on the issue, this is not a discussion necessarily of shortening ramp-up period. What it could mean, though, is there are elements of the waiver initiative that can launch sooner rather than later. And because we are in year 1 from day 1, there won't be any artificial limitations on holding back projects or service delivery that are ready to go sooner than a previously specified time frame. So when the terms and conditions are signed, That is when the first year of the demonstration begins and when the wrap-up period starts. So the questions around planning grants and other financial and administrative support to stand project domains up and to stand the coordinating entities up, everything we have discussed up until now on that front remains the same. With regard to whether HCA staff will be available to help deal with this from an overall waiver initiative and for all of the agencies involved, there will be significant, of course, administrative and contractor needs, both for the project stand-up phase and the implementation phase. And we are planning now accordingly, given the timeline that we're on for those needs, and we'll be addressing them again with both internal and external resources as might be appropriate. So the next question is, what happens to existing backbone organizations if they become coordinating entities under the waiver? And I think, will they be required to become coordinating entities? You know, I believe this is a question that has come up in previous webinars, and I think we've addressed it then. So I'll be pretty short and brief with this question. Our assumption heading into this is that accountable communities of health serve the backbone organization function. If they're unwilling or unable to, we will seek an alternative organization that has the same multi-sector governance and administrative capabilities behind it. With regard to specific back office and administrative tasks, we have always assumed that backbone organizations may rely on contracted services of one kind or another for some of those elements, and that assumption has not changed. The other question we have received is, have other states that have had an 1115 waiver been able to sustain projects beyond 5-year demonstration without having to ask for more money? That is a fantastic question. I feel like CMS may be listening into this call. No, I kid. The truth is, there is a bit of an interesting track record on this, especially with California's recent waiver approval. What we have been told explicitly by CMS is that this waiver, when approved, will be for 5 years, and that is it, and that there will not be, from a sustainability standpoint, additional investment. Even if additional flexibility under waiver approval were to continue, additional expenditure authority would not. They have been crystal clear with us on this and expect, as part of the terms and conditions, for a clear approach to sustainability to ensure that that does not become the case. Have states that have implemented DSRIP projects been able to sustain them beyond the 5-year period without investment? Well, remember that DSRIP is still a relatively new approach to 1115 waiver authority. So I actually think the jury is still out on that. But I will say from CMS's perspective, this is an area of primary focus for them and an area that will be a significant component of the negotiated terms and conditions, again, with regard to sustainability. Projects and demonstrations that prove successful, the absolute intent is for them to be sustained after the 5 years. And again, this is where the ROI and investment analysis comes into place. The intention is not to take proven models of care, proven approaches with Initiative 1 backing and discontinue them after the 5 years, especially if they prove their worth. So there's more to come on that, but an area of primary focus. I'm going to have Marc take a question.
There are two questions here. They're somewhat interrelated. One is discuss the requirements for transformation projects, and the other is HCA has said a contractor will review applications for transformation projects. So what criteria will the contractor use and what will the contractor do? So you may recall from one of the slides and from the project idea guidance that we issued initially, there are some fairly key criteria that not only we will use, but perhaps more importantly, CMS will use in our negotiation with them as to what constitutes the final collection of projects. And really key among those, clearly, is the project focused on the Medicaid population, and is it an allowable use of Medicaid funds? Does it really support Medicaid delivery system transformation goals? And again, those goals were emphasized earlier in the presentation, and really have to do with those key things of improving population health, accelerating the transition to value-based purchasing, ensuring Medicaid cost growth within bounds. And I would add to that other criteria that we have emphasized in terms of the ability to measure progress along the way within the 5 years of the demonstration project, and that means clear criteria in terms of looking at outcomes, processes and outcomes, the milestones that we talked about earlier. And then finally, is the project sustainable? Will it last beyond the course of the waiver period? And that really means as a package of transformation approaches, will we as a state be able to continue on in terms of the good work that's established in the course of the project? We've engaged the services of a contractor to really help us refine those criteria, and also, if you recall the slide that showed the domains, the strategies, the projects, and ideas, really, once again, kind of working from the top down, starting with the domains, and working from the bottom up, starting with your project ideas, coming to a collection of projects and strategies that represent key themes, that represent, wherever possible, collaborations, and not only collaborations between those who submitted the projects, but the ability to transform and transmit the good ideas across ACHs, so that ultimately we end up as a state being able to move forward in a number of different ways, but in very common ways across the various ACH regions. So those are essentially criteria. That's the role of the contractor, and I'd remind you that once we come to a set of projects and in our negotiations with CMS, that information will all be available. The special terms and conditions will be put out for public comment and review by CMS. And so this is not the last opportunity, certainly, to review the project array nor the final project collection that we come to.
Thanks, Mark. I'm actually going to turn over to Melodie and Chris for some questions, I think, more on Initiative 3.
Sure. We have a couple of questions on, this is Chris, on supported employment and supported housing. In an interesting duet, I'll take one and Melodie, you take the second one. So here's the first one. Regarding supported employment and supported housing, looks like most of the resources will be driven out through MCO payments. Are they the best partners to do this? And the answer is, depends on the person. They may absolutely be the best partners to do this. We expect to serve people with supported housing and employment across all of our current healthcare programs. So if a person is being served through a BHO, that may be how the payment for SE, supported employment or housing, is driven out. Same with a person in long-term care. We could have a person with serious health needs, serious medical needs that isn't in any of our mental health services, for example, and the MCO may be the perfect way to drive out that payment. We're still determining the mechanics of this, but our goal is to use current payment avenues to be able to serve people across all of the parts of our healthcare system. Melodie, do you any further comments on that?
Nope, that's exactly the direction that we've been going on. So certainly we're doing a lot of education and training with our MCO partners around these benefits, because I think it is fairly new for the MCOs, but we're certainly trying to do a lot of education and partnership with them. The second question is, can this program be used by affordable housing in a 30%, 60% area median income to pay for a service coordinator? And initially, that, you know, again, these are services per individual, not services for staffing. So these are medical intervention services based on the individual's needs, not on a staffing. Certainly, I think there are opportunities, particularly with Initiative 1, with the Accountable Communities of Health, on how a community can come together and look at the housing issues for their community, and that may lead to some partnerships around service coordination for somebody that for an affordable housing partnership. But it's not to pay for staffing, it's to provide services to individuals.
Great. We have a few more questions that have come in. Thank you for your fast typing here and getting them to us. Not in any particular order. The next question is, as you start to ID strategies under the waiver domains, will you have higher level statewide task force to help drive success in those strategies? What we intend is an open, transparent vetting of project ideas. That is what we have committed to, even as we take those ideas forward to CMS for further discussion. We do not envision statewide task forces at this moment, but would encourage further discussion around project ideas at Accountable Community of Health and other broad statewide association tables, as well as with us directly. We would welcome further input. I'd also remind folks that the comment period is still open for all of the project ideas posted on the website. It can be a bit of an overbearing task, but we certainly encourage people to be selective and choose those ideas that they have the most interest in for providing those comments. We really do intend a statewide discussion. But again, at this stage, are not planning any statewide task forces in addition to those efforts that are already underway, both statewide and at the community level. There's a question for clarification on an earlier slide about that the investments need to be catalysts for reform, not ongoing operating budget expansions. Could you give examples of what would be allowed or not allowed? Maybe first I'll speak to the intent of the statement. The intent of the statement is to be clear that for Initiative 1 purposes, as well as it relates to Initiative 2 and 3, this is not an opportunity to supplant or supplement ongoing budgets for ongoing projects at their present scope. This is about expanding evidence-based interventions to some broader regional or statewide scope. This is about new ideas that are not implemented yet as well, but that have evidence behind them. Again, it is not about, although it would be nice to supplement and supplant existing operating budgets for ongoing improvement projects, if this does not provide that opportunity. I hope that further clarifies that earlier remark, but if folks have follow-up questions, please let us know. The next question is there any nexus between the projects in the toolkit and the work being identified by the Plan for Improving Population Health Work Group? There's a nexus with the waiver in many ongoing efforts, both those efforts financed through the State Innovation Model Grant and under Healthier Washington more broadly. So the easy answer to this is yes. The more, I think, detailed answer, however, is given the timelines associated with some of this work and the design work that's being done now around the projects, is there's not a dependency on that work group. So we'll encourage, especially within the population health domain, some level of interaction and sharing of ideas with the same stakeholders involved in both, but would recognize that we're not creating a dependency on that work group for further project design. Another question in the frequently asked questions file that we would like to address today that came in just a moment ago is how many projects would be selected for the toolkit? You know, this is a great question, I must say. And again, the easy answer on this is we don't know. But here's what we do know. It will not be 100. It will not be 50. It will not be scads of projects, largely due to early CMS guidance on this subject. There will be a focus list of strategies, and Marc was alluding to this, and some of those strategies will have sub-elements in project designs, and further elements of those will be fleshed out in the project application phase. So we're not prepared today, especially absent further CMS discussion, to nail down an absolute number, but we are committed to having a manageable number and having some consistency across the state and between regions with the type of projects being pursued. And that forces our hand to ensure that there isn't, 50, 100, or as the case of one of the states doing district now, over 1,000 projects. We know that CMS is not interested in that approach, so we will not even be offering it as an idea for them.
Probably saying that the idea is helping them to figure out how to provide funding.
Sure, I'm not sure if everybody heard that, but the ideas, and 180 of them that have been submitted, as we clarified at the origination of this, were not project applications and are not projects in and of themselves. What we've experienced is in the way of a lot of both helpful duplication and synergy around ideas being proposed. They're helping us feed these into broader baskets that we can then share with CMS for further discussion. And I think it's around that time that we'll give you a better sense for how many different of these project areas we'll be pursuing in that discussion.
Take another one.
Sure, if you have one to take, go for it.
This is Mark. So this question is, in developing a framework for the transformation project template, can you discuss strategies to support connectivity and linkage across domains and projects? For example, would there be incentives based on partnerships across models of care, thus creating a truly integrated delivery system? How do you envision carrying out linkages in large regions? The answer to the first question is yes. Not to be facetious, we do really look for opportunities to identify and foster linkages across provider systems and across domains within the waiver itself. There was an earlier allusion, I think, in the discussion with regard to supported employment and supportive housing, that these are not activities and interventions that are done or envisioned in isolation. It's very important, for example, if we're looking at provision of a supported employment or supportive housing service, to see how the individual served by those services is also served by the broader health system. We're very much looking for opportunities for linkages as we look at the project ideas. So we may have, for example, a project idea that may have initiated from the first responder system, but we may see an opportunity within the idea that's described to link to something else that, say, is more behavioral health oriented. So we are looking for, and ultimately CMS, I think, will be looking for those opportunities to create those linkages. And frankly, I think there's an incentive for us to do that, in that we're looking for the greatest opportunity for return on investment. So if by combining two or more project ideas into a single approach, we can derive more a better outcome and a broader reach, then surely we're going to be looking for those opportunities. So this was a great question, and I think it prompts a good discussion as well. I've got another question here. It says, once project ideas have been selected by HCA, CMS, what is the process for providers to apply to implement them? An RFP, will ACHs be required to select a number of projects from the list? We've envisioned all along that in the list, as Nathan characterized it, that there will be the opportunity to essentially make selections from that. We haven't completely worked out, I think, the process that we would use for achieving that. But the idea really is to foster the opportunity to not only take a look at and evaluate what's on the list of projects, but then to essentially make application for participation. As Nathan mentioned, the project idea solicitation was not an RFP. These are not project proposals or project applications per se at this stage. So it's appropriate to consider that as we move to the stage of actual project implementation, there will be some additional formality in terms of the process, just so that we can be assured, and CMS can be assured in our special terms and conditions, that we have consistent criteria applied. Oh, and I was just reminded that projects will be through the ACHs, that the ACHs will play a central role in the vetting and the agreement with respect to which projects go forward.
A few more questions. The first one is, are there any key takeaways yet from California's renewal special terms and conditions? And for folks not following, California is a state that recently concluded their original district waiver and got a renewal from CMS. But again, it's not something that we should expect. But is there any major takeaways from that renewal that either CMS has raised or staff have identified that would apply or inform Washington development? Certainly we've looked over those at a project team level for that exact reason. But I would say one major theme emanates very strongly from the renewal STCs for California, and it follows suit on what we've seen develop before them in New York and other states as well. For CMS, value-based payment and ensuring how all of our activities are aimed at transitioning still predominantly fee-for-service Medicaid program into one that rewards quality and value is a very dominant focus, and will likely continue to be and will certainly impact both project formation and the final terms and conditions that are realized. It has always been stated as a goal of this waiver to help Medicaid make necessary movement down the value-based payment continuum, and we think CMS is, as evidenced in California and New York, very, very serious about it.
And also, it's much how different we are.
Yeah, and that's a good point. I'm not sure if folks on the phone heard that it's also a commentary on both how Washington State is very different from California and New York, and the opportunity we have in this demonstration to showcase a truly Washington State approach. The themes, though, will remain the same, I suspect, heading into the next phase of this negotiation process. The next question is, and I hope we don't misinterpret this one, but we're going to give it a shot. Do you see the creation of sub-regional integrated delivery systems, recognizing that this will roll up to an ACH coordinating entity? I think what we'll say on that is we absolutely expect in the project application phase, and I should back up a moment, we have always, in previous communications, indicated that integrated care will be a required and statewide project, and that we would expect an integrated care project from every region. But I think this question deals with, will there be opportunity for sub-regional implementation approaches that go to a more either single county or community level location? I think that is something that remains to be seen in the project application phase, but there's certainly nothing that we're hearing from CMS or nothing that we're thinking of that would preempt that approach. What I will say is we do want to ensure that integrated care models maintain fidelity to an evidence basis and are being implemented with that fidelity in every region. And I have one related question, and I think Bea has a few more to address. And that is, does HCA have any preference as to whether a project is operated statewide versus within a particular ACH boundary? I think that may be a bit of a distinction without a difference. Every project will be implemented through regional community activity led by ACHs. And as I was just discussing with regard to integrated care, there may be some project areas, value-based payment is likely to be another one, where we are required to implement something statewide. But whether it's a rural or urban needs that are dividing it, or particular population characteristics, there may be differences in those approaches, and those will be absolutely allowed. So whether projects operate statewide or within a particular ACH boundary will not affect the administrative responsibilities or implementation of the projects. I'm going to turn it over to Bea for
So I have a question here specific to how clients served through aging and long-term support administration would have access to supported housing and supported employment services. And one of the perhaps unique parts of long-term services and supports is the percent of individuals who are duly eligible for both Medicare and Medicaid that we serve. It's between 70 and 80% of individuals in the long-term care system are eligible for Medicare. Half of those are maybe over the age of 60, but probably at least 40% of them are working age. And so as a result, they fall outside of the traditional MCO Medicaid system because they're dual. And many of the people served in long-term services and supports do not have a behavioral health need or a behavioral health need that is severe and persistent and would be served through a BHO. So there are a number of folks who do receive medical services from the Healthcare Authority on a fee-for-service basis, and their primary need is functional assistance to remain living in their own home or they're in a nursing home. So from that perspective, if we want to make sure that the supported housing and supported employment benefit is open to the targeted population of this waiver, then we have to provide some of those services through ALTA. Also, one of the things that we have a concern about at ALTA that's really core to our mission is making sure that people have a choice to live in community-based settings and that they're given the support to do that. One of the issues around housing and the criteria for supported housing that CMS has set out there is this homelessness definition. And one of my concerns about that is that we don't want to say any bed or any roof over our head is fine. If people are in institutions and want to be in the community but need significant assistance to find housing and maintain housing in order to get into the community, they should be eligible for supported housing. So that's really the target population that we're thinking of in aging and long-term supports. And then, of course, in terms of employment, because of the significant functional disabilities that folks served in the long-term care system have, the kinds of services and supports they may need wrapped around them to find and maintain employment may look different than individuals served through the BHOs or the MCOs. So we anticipate perhaps contracting with many of the same providers that the BHOs or MCOs might contract with, but it may be for a slightly different population, and it would be paid on a fee-for-service basis, although we want to tie value-based purchasing into that, obviously, through this waiver. So that's a little bit about access.
Great. Thanks, Bea. A few more questions that we have coming in, so thank you for keeping us on our toes over here. The next question I'm actually going to ask MaryAnne to address. It says, population health seems like a new application of Medicaid funding. Do you anticipate that CMS will be supportive of this different focus?
I guess the best way I would answer that is, really Medicaid supports a variety of population health related activities today. CMS is supportive of that. It's really isolating it or making sure that the focus is on a Medicaid population. That doesn't mean that an approach that's community-wide, community-based, that we would need to support it from a Medicaid perspective, support it for Medicaid clients. So CMS absolutely, in terms of their approaches, their goals, a population health approach is absolutely part of where they see states going in that direction. I think for them, they just don't want to pay for services for individuals that are not Medicaid eligible. So it's really how do we build those projects out or build those activities out and really be able to use the Medicaid dollars to support services for Medicaid clients.
Public purchasing is such a big player.
It is.
Now that if you raise the health of the population, you're going to help Medicaid.
Absolutely.
So
Absolutely.
There is more openness.
So there really is a lot more openness to that sort of an approach. And certainly when you think about we pay for over 50% of the deliveries, 50% of the children in the state are served by Medicaid, it's just going to happen naturally.
Great. The other question we have is around funds flow, and it's how will disparate funds flow from CMS to HCA and then to providers and partners implementing projects? What if the project spans several counties, and what is the role of the ACH or the coordinating entity? I'll take those in the order and then invite others to weigh in if they'd like. The first thing on disparate funds flow is it is appropriate to think of the funds flow in this way because there's an initial distribution that HCA will be responsible for, as is thought of now. And the dollars will flow on the basis of project applications, the evaluation of those projects, and the stated budgets and scored budgets of those projects. Those dollars will flow under our funding model to accountable communities of health, and the project application will dictate the approach to getting those dollars to participating providers. And I think the other thing I'll stress here from earlier in the presentation is this is not like a grant program in that there is not just a set budget and then a distribution of dollars in accordance with that budget. These are incentive-based and milestone-based payments that will come at various intervals and will support a project budget, but will be unlike a typical grant program administration, and I think that's important to remind folks. This is one reason why, by the way, we think it's very important to have local entities providing some of the initial organization and implementation role to stand up these projects, both from an administrative standpoint, but also from a sustainability standpoint. A further question is asked, what happens if projects span several counties? And I might just restate the question and say it spans several regions, which there absolutely may be the case where that occurs, and in fact we would encourage it. And when those projects span several counties, there will still be a regional level implementation plan and project associated with it. And so while there may be a broader region than just one ACH implementing something, there will still be accountability within that particular ACH for standing up the project, even if it is a shared activity. Administrative elements of that could be determined on the basis of a project application. You could certainly envision for a project application an ACH or group of ACHs deciding that a single administrative entity or contracted entity should play a central role given the design of that multi-region project. And there's more to come on that and more to be figured out on that. Specifically with regard to the role of the ACH, this has been something that has been discussed at some length in previous discussions, and I want folks to also look at the frequently asked questions for more details, but in particular with the role of ACH in multi-regional efforts or efforts that may be statewide in nature. It really is twofold. There is the administrative elements, of course, involved and implementation associated, but there's also the accountability for performance, and that is really, really important. There is statewide accountability from HCA to CMS, and there is local accountability from ACH members, not backbone functions here that we're talking about, but ACH members to the state for performance around these projects. So that is a central role that will be in place, again, no matter the scope or span of a particular project. I'm looking around to see if we have any other questions that have come in, team. So I'm going to take a pause here before we really wrap up and conclude. We know we've kept your attention for well over an hour and a half now, so still want to make sure that we are addressing all questions as they come in, so we'll give it just a few moments.
And people still can comment.
Oh yeah, and that's a great suggestion, Jenny, thank you. Folks can still leave questions with us either through our email inbox, as well should be encouraged to post public comments to any of the project ideas that are now posted on the website. And again, I would encourage for those who have not had an opportunity to check out some of the very helpful fact sheets and FAQ documents that are posted on the website, both with regard to accountable communities of health and initiatives. It's a great way of getting some orientation to this subject matter. So let's see, any more questions? All right, we are going to assume that we covered the waterfront. I feel like we did cover quite a few different questions today, and thank you to our panel from both DSHS and HCA for assisting in this. And we'll look forward to keeping this discussion up, both virtually with you as well